Femoral acetabular impingement is a well-described pathologic condition. It consists of cam impingement, which is an overgrowth of the neck of the femur and the anterosuperior aspect, and/or pincer impingement, which is an overgrowth of the outer rim of the socket or acetabulum. Clinically, it presents as either isolated low back pain, lateral hip pain, or groin pain, or a combination thereof of any of the three pictures seen. I describe FAI clinically as a weed. The leaves of the weed represent labral tears, snapping hips, iliotibial band syndrome, groin pull, low back pain, sports hernias, hip flexor strains, SI joint pain, or piriformis syndrome. If these are the leaves on the weed, the root of the problem is FAI, cam and/or pincer impingement. FAI was first described in Switzerland by Dr. Gons in 2003. It is defined as the repetitive abutment between the femoral neck and the acetabular rim that occurs within the normal range of motion. As seen on this axial view, cam impingement is an overgrowth of the neck of the femur, specifically the anterosuperior aspect of the neck of the femur, occurring between 10 o'clock and 2 o'clock three-dimensionally. Pincer impingement is an overgrowth of the outer rim of the socket or acetabulum. Most common is a combination of cam and pincer impingement, occurring roughly in 86% of patients. With pincer impingement, the deep acetabulum leads to ossification of the labrum. The majority of the labral damage occurs between 11 o'clock and 1 o'clock. The labrum becomes ossified. There may be a countercoup injury in the posterior inferior acetabulum. With cam impingement, the aspherical femoral head causes labral chondral injury, typically at the junction of the labral chondral seal. In addition, cartilage may delaminate away from the bone after the labrum fails. Femoral acetabular impingement is a well-defined pathologic condition that can lead to painful cartilage injury, labral tears, and arthritis. Impingement can occur as a result of femoral-sided impingement, known as cam impingement, acetabular rim impingement, known as pincer impingement, or a combination of both. The pincer-type lesion refers to the over-coverage of the acetabulum. In high degrees of flexion, the pincer lesion repetitively hits the femoral neck, resulting in degeneration, ossification, and tears of the anterosuperior labrum. Cam lesions of the femoral neck impinge against the acetabular rim. This can lead to cartilage injury within the acetabulum. This differs from pincer lesions, where the acetabular labrum tends to fail first, often leading to degeneration and eventual ossification of the labrum. In the majority of cases, there is a combination of cam and pincer impingement. The combination may lead to labral degeneration and ultimately cartilage delamination within the joint. FAI in isolation is not painful. Symptoms are caused by the loss of range of motion, which leads to late sequelae. Picture a busy road in your town. Should the main road be shut down, you will take side streets to get to your destination. FAI is the main road. The side streets are the reactive spasm or secondary muscles that you use to compensate for the loss of range of motion between 10 o'clock and 2 o'clock in your hip. The hip is a constrained joint. The socket covers over the femoral head. Therefore, this morphologic change between 10 o'clock and 2 o'clock leads to reactive spasm of the psoas, adductors, abductors, low back, and/or piriformis. Labral and/or chondral injury may also occur. There may be a sensation of symptomatic instability and/or snapping hip, either externally or internally. Clinically, you will either present with an acute or chronic history of groin pain, low back pain, and/or lateral hip pain. This pain, catching and/or clicking is exacerbated by car entry or exit, prolonged sitting, getting up from a chair, impact loading, jumping, pivoting, running, squatting, standing, walking, putting on shoes and/or socks. This may be mild to severe pain. Mechanical symptoms such as snapping, catching, or clicking may be present. Stretching frequently exacerbates the symptoms. With physical exam, there's typically a loss of flexion and internal rotation. Provocative maneuvers, as seen in this slide, will also be performed. Imaging studies will consist of X-rays and MRI arthrograms. X-rays are taken to determine the underlying root of the problem, which is FAI. CAM and/or pincer pathology is picked up on plain radiographs. Further imaging includes MRI arthrograms and/or the possibility of a 3D CT reconstruction. The most common cause of CAM pathology is an asymmetric closure of the growth plate. The femoral neck growth plate starts to close at age 13. It closes by the age of 18 in most patients. Sports, how you sat, posture, repetitive overuse often leads to an asymmetric closure of this growth plate. This does not rule out the possibility of a traumatic cause to CAM pathology, such as a slipped capital femoral epiphysis, or SCFE. Pincer pathology is most common either overcoverage with a center edge angle greater than 39 degrees, or retroversion, which is radiographically seen as a crossover sign on plain film. The normal range of a center edge angle, as seen on this AP pelvis, is 25 to 39 degrees. If your center edge angle is less than 25 degrees, by definition, you have a dysplastic or shallow socket hip. A center edge angle value greater than 39 degrees is equivalent to pincer pathology. In this X-ray, indicative of pincer pathology, the center edge angle is 44 degrees. The acetabulum in a normal hip is anteverted, with the socket sitting 20 degrees forward. With retroversion, the anterior wall crosses over the posterior wall. This is called a crossover sign on plain X-rays. Three-dimensionally, this represents excess bone between 12 o'clock to 2 o'clock, as seen on this slide. These are X-rays of a patient with both CAM and pincer pathology, specifically retroversion and a crossover sign. As seen in the postoperative films, the crossover sign, indicative of retroversion, is corrected, and the CAM is corrected as well. CAM pathology is picked up on either a frog leg lateral or this Dunn view, which is more sensitive to pick up subtle CAM pathology. The CAM bump is measured by the Noetzli alpha angle. Find the center of the femoral head, make a line parallel to the neck of the femur, and another line to where the head loses sphericity. In this patient, the preoperative alpha angle is 79 degrees. Most surgeons agree that an alpha angle greater than 50 to 55 degrees is indicative of CAM pathology. This is the postoperative X-ray after CAM correction, with a 36-degree alpha angle. After X-rays are taken, you will be sent for an MRI arthrogram with a diagnostic marking injection. MRI arthrograms are 74% sensitive, 83% specific. Some recent studies have shown 90% sensitivity. Therefore, MRI arthrograms are not 100% valid in determining true positives or true negatives. This MRI arthrogram is from a professional athlete with an acute injury. As seen on the coronal view, the labral tear was caused by the CAM bump being driven in to the socket. This is a T2 image where the edema or white blush represents reactive change. Your symptoms may be acute, such as from a traumatic injury as seen in these MRI slides, or from chronic femoroacetabular impingement.
Okay.
The labrum is a triangular fibrocartilage structure that surrounds the outer rim of the acetabulum or socket. It is absent inferiorly, roughly from 4 o'clock to 6 o'clock. The labrum's function is to provide joint congruity. It increases the surface area 22% and the acetabular volume 32%. It enhances stability, providing a fluid seal for the central compartment and negative intra-articular pressure. It decreases the coefficient of friction and provides resistance to lateral motion, as well as proprioception and nociception. Labral tears most commonly occur between 10 o'clock and 2 o'clock. Breach of the integrity of labral function leads to decreased femoral stability during extreme ranges of motion. Femoral acetabular impingement is a prominent contributor to anterior hip pain and early hip osteoarthritis in active patients 20 to 50 years old. Molecular analysis of FAI cartilage has found arthritic precursors. There are always options in life, both non-operative and operative, specifically to FAI pathology. Once your hip becomes symptomatic, conservative treatment is unlikely to be effective. Conservative treatment can include activity modification, stretching, or other modalities such as chiropractic management, dry needling, and deep tissue massage. Intra-articular injections of a local anesthetic such as Marcaine or Ropivacaine may offer diagnostic value. Surgical correction of femoral acetabular impingement used to be an open procedure, requiring a formal dislocation of the hip. With the advancement of technology and surgical technique, this is now an outpatient surgical procedure. A torn labrum is the sign of an underlying problem. When treating labral pathology in the hip, the underlying bone pathology must be addressed. Failure to address bony impingement, cam and/or pincer pathology, is the key factor in unsuccessful hip arthroscopy. Let's go through some cases. Should your IT band be symptomatic, the first part of your surgery will involve an arthroscopic iliotibial band release. As seen in this slide, when lying supine, the source of pain in patients with iliotibial band friction syndrome is a bursa on the posterior aspect of the greater trochanter. When performing an iliotibial band release, the iliotibial band is released in line with its fibers, with careful tension made to avoid any damage to the underlying gluteus medius attachment to the greater trochanter. A window is created so that no more friction occurs between the iliotibial band and the greater trochanter. An iliotibial band release does not cause a functional and/or cosmetic deformity. This first case will demonstrate a labral repair, pincer, and cam takedown. A 4.5 or 5.5 millimeter burr, as seen in this slide, is brought through the anterior portal to take down the pincer pathology. In this patient, the labrum is not sealed to the articular surface. There is a labral chondral tear. The labrum is healthy and repairable. A cinch stitch is created and anchors are placed to repair the labrum. This anchor is not metal, but biocomposite, which means it grows into bone. This slide shows a labral repair with anchors placed roughly at the 11 o'clock and 1 o'clock position. Next, after traction is let down, the cam pathology is addressed. In this slide, a 5.5 millimeter burr is brought in through the anterior portal, and the cam is taken down. The convex cam pathology on the anterior superior aspect of the femoral neck is corrected and the normal concave relationship is restored. This second case is a labral repair, pincer, and cam takedown. The pincer is addressed. The labrum is once again detached from the acetabular rim at the labral chondral seal. The labrum is healthy and repairable. Sutures are passed. Anchors are placed, traction is let down, and the cam pathology is corrected. During cam takedown, the hip is flexed to 35 to 45 degrees to ensure restoration of the normal anterosuperior concave junction. This is a view from the anterolateral portal showing successful cam and pincer takedown, as well as labral repair, with the anchor placed roughly at 12 o'clock. This next case shows a labral debridement, pincer and cam takedown. Once again, the pincer is taken down with a burr brought in through the anterior portal. In this patient, there is no violation of the labral chondral seal. Instead, the labrum is torn on the undersurface. A shaver is brought in through the anterior portal to address the pathology. Traction is let down and the cam is addressed. This slide highlights the fact that cam pathology occurs on the anterior superior aspect of the femoral neck, roughly between 10 o'clock and 2 o'clock. With cam correction, there should be no risk of avascular or osteonecrosis of the femoral head. The vast majority of the femoral head blood supply is from the lateral retinacular vessels of the medial femoral circumflex artery. Cam pathology is on the anterior superior aspect of the femoral neck. The lateral retinacular vessels are found on the posterior aspect. Therefore, with proper cam correction, these vessels should not be at risk. This next case shows a labral debridement and pincer takedown. In this patient, after the pincer pathology is corrected, the labrum, as seen in this slide, is irreparable. A shaver is brought in through the anterior portal and the labrum debrided to a smooth rim. This final case demonstrates a labrum reconstruction, cam and pincer takedown. Should your labrum be irreparable or absent, a labral reconstruction may be indicated. At the present moment, the absolute contraindication for labral reconstruction is joint space less than 2 millimeters. In this patient, the labrum is irreparable. A shaver is brought in through the anterior portal to debride the unstable tissue. The underlying bone pathology is then addressed with pincer and cam takedown. The defect is then remeasured. You can see an absent labrum roughly between 11 o'clock and 2 o'clock in this patient. Autograft or allograft tissue may be used for labral reconstruction. Allograft tissue is cadaveric tissue. This tissue is tested, cultured, and frozen. It is not irradiated. There is no increased risk of infection. In this slide, an anterior tibialis tendon is used for labral reconstruction. The whip-stitched cadaveric tendon is brought in through a mid-anterolateral portal, anchored and placed so that the labral seal is reconstructed. This slide shows a successful labral reconstruction with this cadaveric tissue and restoration of the labral seal. 2 recent studies have found excellent outcomes with labral reconstruction. 76% survivorship at 56 months, and in a second study, 85.7% of elite athletes who underwent a labral reconstruction returned to play, with 81% returning to the same level as their pre-injury status. Typical recovery after FAI correction, labral repair, and/or labral reconstruction is 3 to 6 months. Time 0 is not the date of surgery. Your baseline function will be determined by both a Biodex isokinetic test and a functional step-down test performed prior to the date of surgery. The specifics of your postoperative timeline, care, and therapy can be found in the additional videos on this website.